Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith Rogers. Ketamine is in the news again. Today, Dr. Paul Kim, a psychiatrist and director of the Johns Hopkins Treatment-Resistant Esketamine Antidepressant Targeted, or TREAT, Depression Clinic, and co-director and psychiatrist Dr. Paul Nestadt, talk about the differences between ketamine and esketamine, an FDA-approved medicine for treatment-resistant depression. They also talk about why ketamine is in the news right now and the importance of administering esketamine in a clinical setting as part of a broader comprehensive mental health strategy. Let's listen. Dr. Paul Kim and Dr. Paul Nestadt, thank you so much for coming on Public Health on Call. So today we're going to revisit a topic that we've talked about before but is trending in the news again, and that is ketamine. But first, what are the differences between ketamine and esketamine? Dr. Kim, could you walk us through what these two things are and how they're used?
Sure. Thanks for having us on. Difference between ketamine and esketamine. So when people talk about ketamine, it is a mixture of both this S and this R ketamine. The S and R ketamine are mirror images of each other. And so while they are chemically same, they are structurally different. So like your right and left hand, they are very similar. They have 5 fingers, but they're mirror images of each other. And, you can't superimpose them on top of each other. And esketamine is just a purified form of that mixture. So they have synthesized this one form of ketamine. And ketamine has been used for a very long time. Was in the 70s FDA approved for its use as an anesthetic, and later it became popular as a recreational drug. Now, esketamine, on the other hand, was just recently approved by FDA in 2019 for its use for treatment-resistant depression, which really means that people who have tried a couple of oral antidepressant and they did not respond to it. So it's approved for that. And it's also approved for major depressive disorder with suicidal ideation and behavior. The idea is that it alleviates suicidal thoughts in a more rapid way.
We've also heard that ketamine, and correct me if I'm wrong, but ketamine is being used in opioid use disorder. And I think there's some confusion about whether ketamine is an opioid. You mentioned that it was used at one point as an anesthetic. Could you talk a little bit about that?
Yeah. So unfortunately, ketamine has been used sort of off-label for many different use disorders, like, as you mentioned, opioid use disorder and PTSD and numerous other disorders. But they haven't been approved by FDA for those uses. And so ketamine typically isn't considered an opioid at all. Although, there's some evidence that at a higher dose, it may bind to the opioid receptor. So for those reasons, there's concerns about abuse potential and addictive nature of ketamine, but it really hasn't been proven to treat opioid use disorder.
So let's get a little more into the details about esketamine and its use for, you said, major depression and treatment-resistant depression. So Dr. Nestadt, could you talk to us a little bit about your research and how this is used as part of a comprehensive strategy?
Yeah, absolutely. So esketamine is one of the newer treatments we have for depression. Major depression has been a major issue in the United States and globally. It's a major cause of workplace disability. It's, of course, a contributor to suicide. Suicide rates have been climbing dramatically for the past 20 years. So when a new mechanism of treating depression was sort of discovered, when ketamine was found to be helpful for depression, people were very excited. I mean, early on, the research was in ketamine, this racemic mix of drugs that Dr. Kim was describing. And that was found to be somewhat effective, although it wasn't studied as extensively as esketamine. esketamine, this purified form of ketamine. This purified form of ketamine has been studied by the FDA in several large, what we call phase 3 trials with multiple sites, and found to be very effective in treating treatment-resistant depression, depression that hasn't responded to other treatments. How it works is generally you come in to a hospital or a clinic in a supervised setting, and you're administered this drug. It's actually given intranasally, which means like you might take like Claritin, you sort of squirt it up your nose. A doctor's there to monitor you. Because it's got potential side effects, including things like blood pressure increases and nausea, that kind of thing, we do it with a doctor present. In our clinic at Johns Hopkins, a patient comes in, they're monitored via a protocol that the FDA set for esketamine, where they're there for 2 hours. Doctor is physically present to check blood pressure at specified intervals to make sure blood pressure is not having any problems. If someone gets nauseous, we have medicines for that. If they get a headache, we have medicines for that. They're given on the first day a relatively low dose to make sure that there's no major side effects. We use 56 milligrams just for context. And then they come in twice a week for the first month. They come in twice a week. They get that treatment. We go up, if they can tolerate it, to a dose a little bit higher, of 84 milligrams, and they stay on that dose. After a month of getting this treatment for twice a week, we're assessing every time they come in if their depression's getting better or if they're having any side effects. And after a month, we sort of make a decision with the patient whether they think it's helping. If it's helping, we continue that treatment, but we taper it down. We go down to once a week for a couple of weeks, and then every other week, and then every month or so. And we taper the treatment down because they've gotten over that hump of depression. And importantly, they're also taking other medications and other treatments for depression that whole time. So vast majority, I think almost all of our patients are on other treatments as well. They might still take an oral antidepressant. They're encouraged to be in therapy, specifically things like cognitive behavioral therapy, which works synergistically with the esketamine treatment. And we have seen remarkable results. We've seen people that have been depressed and resistant to treatment. Treatment hasn't been working for decades in some cases, seeing good psychiatrists. When we first opened the clinic, we were seeing a lot of people that were in the Hopkins psychiatry program, but had been unable to reach success in their treatment for decades. And then they come to this program, and often they see relatively rapid improvement, not same day. People might feel good that first day with treatment, but really that sustained improvement can come within a few weeks by the end of the month. And then we potentiate that with further treatment. People tend to do pretty well. We rarely do see those side effects of high blood pressure, but it can happen. And when it does, we're prepared. That's why it's so important that someone's in a clinically monitored setting. We have what's called a crash cart, the medicines that can help bring their blood pressure back to normal if they need. Very rarely used, but it's important to have. And also because it can be a strange experience using this medication, it can be helpful for a patient to know there's a doctor right there. I think that's essential. I worry about when it's given in an unsupervised setting, but fortunately, esketamine, this form of ketamine, is regulated in such a way that it's only legally allowed to be given in a supervised setting.
Dr. Kim, what is the patient experience of this? So they come to the clinic, they are administered the medication, and then you said it takes about 2 hours. What happens during those 2 hours?
Yeah, so during those 2 hours, the real experience happens during the first hour where they have these dissociative effects. So ketamine is a dissociative anesthetic. And so this esketamine, even at this lower dose, also has some dissociative and sedative effect. So during that time, they sort of feel disconnected from themselves. That's what it means to be having those dissociative effects. So their thoughts that they may have body experience, right? So they feel disconnected from their body or feel that the speed of the time has changed in a certain way. So the things that they experience during the first hour or less. After that, they come out of it and they're back to their normal self.
Is there a hallucinogenic effect to this? Or I'm trying to fully understand what you mean by they're outside of their body. Are they lying down? Are they daydreaming? What is that like?
Yeah, so there isn't really a true hallucinogenic effect with esketamine, but they just feel a little bit out of it. They feel a little bit strange. So typically they're not seeing visions or hearing voices, anything like that. Yeah, it's just different is a lot of times what the patients tell us. They can't quite describe it. And what they're actually describing is this common effect of these types of medicine, which is the dissociative effect.
It really varies a lot per patient, but some patients will describe things like feeling like they're in a tunnel or feeling that their body is very large or very small or just feeling kind of out of it. And remember that we're using a much lower dose of this drug than someone would use if they were using it recreationally. So it's not as severe of an effect. Oftentimes, the first time or maybe first and second time, they might feel that, but after they've had a few treatments, some patients bring their laptop and are doing work, doing emails, that kind of thing.
And Dr. Nestadt, I also want to ask you, sometimes with drugs for depression like SSRIs, sometimes people are looking to esketamine because the side effects from those drugs are so they almost counteract any benefit that the patient is getting from them. So you mentioned some side effects that are happening in the room at the time. They might get nauseous, have low blood pressure. Are there any side effects that they might have outside of the sessions over the time that they're using this drug?
Well, that's a great question. We get patients asking that all the time. It's also worth pointing out that most people on SSRIs, most people that use SSRIs, don't have any side effects. Some people do, and their side effects that can be bothersome, like dry mouth or headache or nausea. But most people do pretty well. But yeah, there are people that are very sensitive to those side effects, and they do look for other treatments like esketamine. With esketamine, the vast majority of the side effects you might encounter are going to be in the session, and they're nausea, or maybe the only really dangerous one that we worry about is this high blood pressure spike, which happens during the session. It's why we keep them in the hospital for 2 hours. Outside of the treatment session, there's not very much that we've ever heard people experiencing. The clinical trials didn't find much in terms of side effects outside of the treatment. It's worth pointing out, though, that ketamine, the mixture that includes esketamine, when it's been used recreationally or chronically, there are people that have given reports of things like bladder problems, where they're using high doses or very frequent doses, or using it chronically for years and years. They can have things like bladder problems, and there can be cognitive problems. And there's even been reports of people that have been using it chronically, frequently, having psychotic symptoms outside of the treatment setting. So people might have delusions, that kind of thing. But again, this is people using it unsupervised, high dose, chronically, and frequently, not what happens in a supervised treatment setting.
We're hearing a lot about ketamine in the news. What should people know about this, Dr. Nestadt?
Yeah, so when you see ketamine in the news, because of the way that news reports things, it's usually on extremes. So for a while, ketamine was in the news because it was a wonder drug, this miraculous thing that could finally treat depression quickly. And it was even marketed sometimes in the media as being used for things besides depression, like, oh, there's some promising evidence for OCD or PTSD or arachnophobia or whatever you could sell it as. And that's unfortunately what happens sometimes when there's something new. People get maybe overexcited. There's some hype. And then, people started to look for places to get ketamine wherever they could, and these private businesses would pop up, and they were marketing ketamine. And remember, this is the racemic mixture of ketamine, not this purified FDA-approved version. It was being given in unsupervised settings. It was being shipped by the mail. You could sign up for companies that would ship you ketamine. Maybe they'd ship like a scented candle with it or something, because there would be the idea that you'd want to have the setting matter, that kind of thing. And because it was unsupervised, and to be honest, the patients weren't that well assessed before being prescribed the ketamine, there was all kinds of bad outcomes. I mean, there was diversion, but also, when we see a patient in our clinic, the first step is a long 2-hour interview with a psychiatrist where we get to know if this patient actually has treatment-resistant depression, as opposed to they're demoralized, they're grieving, they're anxious. Lots of things can look like depression to an untrained person. But these people are getting it for all kinds of things being sent. That created a lot of news because of the abuse, the misuse, in some cases, unfortunately, really tragic outcomes. Of course, the actor Matthew Perry died because he was being prescribed a lot of ketamine in a way that was given unsupervised. It's also in the news because it's become popular, like in Silicon Valley, right? Famously, Elon Musk sort of reports that he uses ketamine on a very regular basis on his own, that his doctor gives it to him to administer to himself. And people have worried that might have chronic effects. Notably, the biggest name in private ketamine distribution is a company called MindBloom, which has popped up all over the country shipping ketamine. And interestingly enough, the co-founder of MindBloom, the wife of the founder and the chief engineer, now works for Doge. And so there's all these sort of interactions between the ketamine world and things going on in the federal government and the tech world. So it's in the news. And I worry that might be giving potential patients, the wrong idea about what this medicine is, as opposed to what this, I guess you could say, what this drug is. The medicine, the Spravato, which is the brand name for esketamine, is a very different animal, supervised and helpful and proven with evidence to be effective.
And that's also a good segue to this question, and I'll direct this to you, Dr. Kim. So you're doing all this research. What more do we need to know about esketamine?
Yeah, I think one of the biggest question that we still have is exact mechanism. of esketamine. We just really don't know. Ketamine, it's primarily used as an antagonist for this receptor, NMDA, but it potentially may be acting at another receptor, as well as its metabolite. Esketamine and ketamine's metabolite might also play a role in having this antidepressant effect. So I think that's the next step, because what esketamine and ketamine has done is sort of go beyond this serotonin model for depression and start looking at other possible ways of treating depression. And I think I imagine those would be the next steps.
And Dr. Nestadt, I'll end with you here. Do you think there's other uses for these drugs that maybe we haven't looked into yet?
Well, there are people that are doing active trials for other sorts of indications. So maybe there is some evidence that it potentially could help in other psychiatric conditions. It's worth pointing out that it's also used in the treatment of pain. And that's been something that's been FDA approved for even longer than for depression. But yeah, there's trials going on for OCD. There's trials going on for PTSD, even for anxiety disorders. And I think you alluded to one for opiate use disorder earlier in the interview. These are all happening. But it's important to recognize that those are trials that are ongoing. They're not completed. We don't know yet. And in medicine, it's really important that we don't jump the gun, because we're dealing with people's lives. So we don't want these drugs being given for things that we just have a hunch they might work. They're not 100% benign. They require, safe monitoring. So yeah, there's certainly potential out there. But right now, what we know esketamine works for is treatment-resistant depression, and it also can work for suicidal thoughts specifically. And so we treat those conditions.
Well, this has really brought a lot of context to the headlines. We really appreciate your time. Thank you so much, Dr. Kim and Dr. Nestadt.
Sure, thanks for having us.
Yeah, you're welcome.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast